My name's Dr. Allison Luke, and as was noted earlier, I'm a research associate and associate director at the Center for Research and Integrated Care, which is housed at the University of New Brunswick and the St. John campus. And I was part of a great team. And Pam Jarrett, Dr. Pam Jarrett, one of the leads on that team, is here today. And we implemented a project called Navigating Dementia New Brunswick. So today I'm just going to give you an overview of what that project looked like and the evaluation results. I'm just going to see how to, there we go. So just very quickly, here you have a list of our principal investigators. So Dr. Shelley Doucette was unable to join us today. She's the director for the Center for Research and Integrated Care, and also one of the leads on this project. And I should note that this project was funded through the Healthy Seniors Pilot Project. And very quickly, our research team, projects like this don't just happen with a couple of people, and there's a lot of hard work that goes on behind the scenes. So I'd like to thank Dr. Lillian McNeil. She was the primary sort of force behind making sure all of this happened. She was the project coordinator housed out of the University of New Brunswick in our lab. Carla Fegg, a research manager with Horizon Health, made it possible for us to navigate what could be a very complex process of identifying possible navigators and getting them hired and set up within clinics across the province. Sherry Gionnet acted as our clinical coordinator, which was a really key role. And Corinne Legere was out of the University of Moncton, and she provided more coordination support. And we also, of course, had our 6 patient navigators. But I want to draw your attention to our patient and family advisory committee. We had 5 members on that committee, people who live with dementia, living with dementia, as well as care partners. And they provided invaluable expertise, guidance, and support, and they helped to oversee the entire implementation of this pilot as well as the evaluation. And Carol Marsh, who is pulled out here, she was one of the co-chairs of that committee and actually sat in on all of the main organizing meetings for this project. So just to give folks a little bit of a background, I mean, I'm not going to share information that most of you probably don't already know or have not heard about, but the rate or the number of Canadians living with dementia, both in the country as well as in the province, is going up. So currently we know it's around 700,000 Canadians live with dementia. In the province, I think the number is around 12,000. And with this increase, and again, this is not new to most people on this call, we see increasing impact on care partners as they face more barriers, increased burden in their informal caregiving roles. One of the things that we conducted out of our lab prior to implementing this pilot was a needs assessment. So in a needs assessment, the idea is you really want to try and talk to as many folks across different interest groups as possible to get a real sense of what are their experiences in accessing and delivering care, and then what are the gaps and barriers and facilitators when trying to access and deliver care. And then we, as a part of this needs assessment, we also wanted to look at what sort of program, like a navigation program, what would that look like if we were to implement something like this? So this kind of needs assessment helped to inform the implementation of this pilot. And one of the big things we found from that needs assessment, and this was across the board, was that there was a real difficulty navigating the system. And this wasn't just what we heard from people living with dementia and their care partners. This was from geriatricians, decision makers, other health and social care providers like nurses, people or primary care providers who would say to us, I know I'm expected to do a certain amount of navigation, but I don't have all the tools, the skills, or the time to do this properly. Because as we know, in terms of the services and the resources that are available in New Brunswick, in your community, it's a moving landscape. It's always changing. There may be new programs, there may be new eligibility criteria. Some things get funded, some other things get defunded, and it's really challenging to stay on top of this. So across the board, we heard that navigation was a key concern. We heard that people felt there was limited access to social and health care, as well as a lack of knowledge and education around available services. And one of the biggest takeaways was that our care partners expressed that they were experiencing very high levels of burnout. So in terms of patient navigation then is a possible solution to help address a number of these issues. And I should note up front that patient navigation does not currently have like a standard definition or a standard scope of practice. So I want to give you a bit of a background of where it comes from and then how it informs the program that we developed. So patient navigation came out of the United States. It's a relatively new program. It was developed in 1992 by an oncologist, Dr. Harold Freeman, and he was seeing poor health outcomes and all kinds of challenges and barriers, especially for uninsured, low-income African American women with a diagnosis of breast cancer. And so he looked at these issues, and he decided to implement what we now call patient navigation. So he came up with this idea of having navigators as individuals who could help guide people through what we know can be a very complicated and a very fragmented system. So in terms of like since that moment in 1992, navigation has exploded, especially in the cancer care space. It's moved into supporting children and youth with complex care needs, people with mental health and addiction concerns, with HIV and AIDS, seniors, various chronic conditions, and of course, dementia. And we've seen it even grow in terms of its popularity within the Canadian context. So for us, navigation is a program, but it's a program that depends on a person. It's a role. So it's not just like a website. Websites can be tremendously powerful tools like lists of resources, repositories for resources, but you need that person who then can work with patients, care partners, or members of the care team. So clients can be any of those three groups or together, they can come as groups, but to help them to proactively guide them and support them as they move through the system and try to help them find and connect them to those appropriate resources and services. The end goal of navigation is to reduce the fragmentation that we know exists in our healthcare system, to improve access to care, another hot topic in terms of things we want to achieve in our healthcare system, as well as to promote the integration of care. So the current project, this pilot is called Navigating Dementia New Brunswick. And we had four basic objectives that went with this project. So the first is to increase knowledge of health and social services and resources, to connect people to appropriate health and social services, resources, and supports, to facilitate the integration and coordination of care, but also to assess the facilitators and barriers to implementing this program. And this was key, and it was a really important part of the Healthy Senior Pilot Project. So one of the goals of that whole funding program was to not just fund projects or fund pilots, but to really invest in pilots such as ours that could be scalable, that were sustainable, that had the possibility to be actually moved into everyday practice and existence. So it was really important that we also looked at what worked and what didn't work when we were trying to implement this program. All right, so in terms of implementation, this program was piloted across 6 different health centers across New Brunswick between July 2022 and July 2023. So although we were in the 3rd round of Healthy Senior Pilot Project funding, we had approximately maybe just shy of 18 months to roll this out. So you can imagine the first few months leading up to it, we really felt it was important to have a co-design phase because one of the strengths of patient navigation is because it is flexible and adaptable, and it is important to meet with the various different health centers to make sure that the program is implemented in a way that it meets their unique needs depending on where the clinic or health center is located. So we use that time leading up to it to really get everything in place, to identify navigators, to get them hired through both Vitalité and Horizon Health, trained, set up to get everything in place. So by the time that was done, the pilot itself, the actual program ran for 1 year from July to July. I should just note that we had 6 navigators, and they came from a variety of different backgrounds. So we had registered nurses, social worker, someone from public health, as well as someone who had a lay navigation background. So they weren't a healthcare professional, but they'd worked in care navigation. In terms of recruitment, so recruitment, like any study, you need to recruit for participants to be part of it. But in this case, we were recruiting for people to get in touch with the navigator and to receive support and care through the patient navigation program. And to accomplish this, we relied heavily on all kinds of, brochures and business cards, social media, media releases, but the community outreach was really key. So we leaned heavily on our navigators and their knowledge of their communities to get the word out about this navigation program. In terms of the evaluation, just so you have a sense of what we wanted to achieve, we were interested in three basic things: who enrolled in the program and how did they use it. So for this, we leaned on the navigation chart data. So navigators collected all kinds of information when they were working with clients. We were also interested in the experiences of participants who enrolled in the program. So for this, we had satisfaction surveys as well as semi-structured interviews that we did with people who enrolled in the program. And then finally, we were looking at the facilitators and barriers to implementing the program. This was accomplished with post-intervention focus groups. And I should note that the focus groups were conducted with everyone from the research team, the navigators, people, health and social care providers, so it could be clinicians, people within Horizon, for instance, who helped in the sort of rolling of this out so that we could really learn what worked and what didn't work. So I'm just trying to find my little arrow. Oh, here we go. Keeps moving on me. All right, so in terms of participant characteristics, we had 150 people enroll in the program. And when I talk about a participant, I should just note here that we're talking about the whole sort of clinical case. In this case, the bulk of them, and really it was the majority, were dyads. So people came to the Navigator and enrolled in the program typically as a care partner and a person living with dementia. So, in terms of the age of people living with dementia, the range was between 43 and 96. In terms of the age for the care partners, it was between 29 and 90. Most of our people living with dementia, well, just a little over, were females. So, but it was almost a 50-50 split. But in terms of the care partners, almost 75% were female. And I can point out that in terms of care partners, the bulk of them were spouses, and then most of the remaining care partners were children, adult children. Most were English speaking, and interestingly, most were actually about 60% lived in rural areas. And if you look at our participant sites here, you can see that they were Fredericton, Rogersville, Lamech, Blacks Harbor, Minto, and Riverside, Albert. That other than Fredericton, a lot of our sites were in more smaller communities or rural areas of the province. So this is kind of interesting. I should point out that in terms of referral, we did not require people to get a referral from a particular health care provider or their primary care provider. We allowed it to be wide open, and self-referral was also an option. We made this decision primarily because we know a number of people may be unattached and didn't have a primary care provider who they could get a referral from, or even if they did, maybe they wouldn't be able to get an appointment to get a referral. So we kept this very wide open so that the program was really accessible. Interestingly enough, the bulk of our referrals came from the Alzheimer's Society. It was noted early days when we wanted to implement this. There was concern, I guess, that people said, are you duplicating what the Alzheimer's Society is doing? And are they involved? And, you want to be careful you're not stepping on any toes. And well, first I can say the Alzheimer's Society, we had worked with them when we were doing the needs assessment phase. They were part of that. We met with them a lot. And as you can see here, that they referred, the good chunk of our clients came from the Alzheimer's Society. So we wound up having this really wonderful relationship where they were able to do work with patients and clients that they had capacity to do. And then often if it was something maybe they required more hand-holding, really helping to fill out forms, that kind of stuff, they would refer them on to our navigation program. You can see a lot of other folks, a good chunk were self-referred, and then people also got referrals from the study site, extramural, primary care provider, and a small number from long-term care facilities. Just out of interest, the bulk of our clients who were living with dementia had a diagnosis of Alzheimer's disease or undefined dementia. And I can also share that 51% of our clients who were living with dementia had seen a specialist. All right, so why did folks come to our program? And this slide just gives you a bit of a breakdown and the reasons we saw um, why people expressed an interest in needing support. The number one reason was to access programs that were offered through the Department of Social Development. So navigators would really help to connect, to fill out forms, to look at eligibility requirements, and all of that stuff. But that was the number one reason why people got in touch with us, followed by looking for support for care partners and people living with dementia to stay at home, looking for specific information around dementia support, information on advanced care planning, looking at community-based resources like respite, as well as looking at information for home health care. So as I noted earlier, we handed out surveys. So everyone who participated in the program had an opportunity to fill out a survey, and we had 56 responses. Most of those responses, 95% of them, in fact, came from care partners. They were primarily female, and they were primarily Anglophone, and 82% of them said they were very satisfied or somewhat satisfied with the navigation program. But I'm going to break this down a little bit for you so you can see drill down to some of the more specific questions. So what we can see here is that a good chunk of our respondents were very satisfied with the health and social services they received from the navigator. They were satisfied with the resources provided by the navigator. They expressed that they had improved knowledge of health and social services, as well as improved access to health and social services. Respondents also reported that they were satisfied with the improved level of communication. We definitely saw improved confidence, decreased social isolation, and then somewhat satisfied with an ability to stay in the community. And I just want to speak a little bit to some of these results where you see that gray bar, which is a little higher in the middle, which represents neutral. One of the things our navigators noted very early on in the program and rolling it out was that the bulk of the people who were getting in touch with them were already in a state of crisis. They'd been on this journey for years. The person had been living with dementia for a number of years. Care partners were burnt out. We had some horrifying cases of people they were just desperate for support. And they were already at a place where they needed that long-term care was the solution. So keeping them at home was not going to be an outcome in those cases. And some of this stuff I'll speak to more when we talk about the interview findings. But I just wanted to note that this was something that, given there hasn't been navigation support, it really spoke to how much it was needed to see this level of crisis and desperation, frankly, that people were in when they got in touch with our navigators. So very quickly, we did 36 interviews. So everyone was offered an opportunity to be interviewed. We had 36, and all interviews were with care partners. So we came out with 5 sort of broad themes that fall under benefits and then recommendations for the program. And the benefits were things around that they felt that they were supported emotionally. And we have seen this a lot in navigation in terms of people feeling that they just had someone who was in their corner and they were listened to, and how important that is. They also felt that the navigators provided appropriate informational resources, as well as they had an ability to connect them to the services they needed to get to. In terms of recommendations, one of the big recommendations that came out from a number of our interviews was that they just wish they could have accessed the navigator sooner. And this really speaks to that crisis bit that I was referring to. People came in saying, well, I've already, I was hoping you might have a list of other services I could access, but they'd already found a bunch of the services because they'd been doing this on their own for so many years, and they'd been struggling, and they were tired, and they were stressed, and they really wished that they could have had a navigator that they could have, say, connected with around the time that they got that diagnosis. They also recommended that we needed to look at ways to address the barriers in terms of accessing services within the program. So this so much isn't a recommendation. It's not something the navigator per se can do. It was that the navigator sort of butted up against wait times, financial issues. So, for instance, co-pays, where some of the clients who had gotten in touch with navigators now found themselves in a place where they couldn't afford the co-pay to access a particular program, say through social development. What navigators and what we built into our system is that our navigators were documenting all of this so that when there were barriers and gaps to be identified, they were keeping note of this. And then we wanted to find a way to get this information back to people in government so that hopefully these things could be addressed. And I'll just give you a quick, I've got a number of quotes, but we've got a few from our care partner quotes from the interviews. It was great. I've recommended it to several people. The system shouldn't be this complicated, but as long as it is, navigators are essential. Everyone should know about and have access to this program. What we appreciated about this program was that we could access it without actually having a diagnosis for my mother at the time. Also, to have a real person, and better yet, a nurse to support us in navigating the system to apply for support. The face-to-face approach, coming to your home to patiently walk you through the steps of the process has meant more to us than you will ever know. So in terms of facilitators, when we actually rolled out this program, one of the key things that we found after talking to members of our research team and the navigators and the clinicians who worked on this is that having connections within those communities to health and social care systems was really key to helping this roll out in a more seamless manner. Also, having access to appropriate staff. So finding people who have strong problem solving skills, listening skills, those kinds of things. That's really key, obviously, to rolling out any kind of program. And then having access to good training. So we fortunately found a program through, at the time, it was offered through York University, and it was a micro-credential on navigation, which we had used in a previous navigation pilot we'd done, and it worked quite well. It was a week-long, maybe half days workshop, and we also provided our navigators with dementia-specific training. So in terms of some of the barriers, the compressed timeline, this is kind of part of any sort of research type project. We were on such tight timelines to get everything in place, roll everything out, recruit, get people into the program. And then, of course, before we knew it, we were coming up on 8 months and we were thinking, oh gosh, we can't enroll new people because, we've got to wrap things up in a couple of months. So you just sort of always felt that it was tight and we didn't have, the time we would have liked to have, but that's the nature of pilots. A second and probably a really predominant barrier is navigating to nowhere. We've seen this in a number of navigation programs. So you can have the best person in the world with the best training, but one of the things that can come up, it can be a big gap, not so much a barrier, is just an absence of services in some communities. And again, this is something that navigators can document, can report back, and help support people as we try to get the necessary programs and services in place. So finally, next steps. What I can say is, overall, we were extremely, excited about the evaluation and the rollout of this program. And we've been very pleased that the Department of Health has committed to implementing patient navigation in the province. So Dr. Jarrett, myself, and Shelley Doucette, as well as our program coordinator, we all sit on the advisory committee to oversee the implementation of this. So we're really excited about this in terms of next steps. And I would just like to thank you all for your time. And